I know that many of you have heard the same sobering stories from constituents, physicians, hospitals, administrators, and parents. Our rural hospitals are entering a financial and workforce crisis. And as an emergency care physician and the former CEO of an emergency department management and staffing company, I know firsthand how desperate the situation has become, and it's only gotten worse in the recent years. My home state of Tennessee is greatly impacted by rural hospital closures and limited access to emergency medicine. According to U.S. News and World Report, Tennessee has seen more hospital closures than any other state besides Texas. In fact, the Tennessee Hospital Association estimates that as many as 45% of Tennessee's hospitals are at risk for closure. This is an impending disaster, not just for the loss of care in those communities, but also the loss of jobs. Often the hospitals are the largest employer in their communities. In order to combat this worrying trend, I've introduced 3 pieces of legislation as part of my broader rural healthcare initiative. Firstly, let's start with H.R. 1128, the Rural Healthcare Access Act, which is endorsed by the National Rural Health Association and the National Association of Rural Health Clinics. This bill targets rural hospital closures by expanding the federal definition of critical access hospitals. According to the American Hospital Association, over 130 rural hospitals across the country closed their doors from 2010 to 21, and according to a GAO report from December 2020, the median distance of travel rural patients drive to receive care increased by 20 miles, adding an ever-expanding barrier to essential inpatient and emergency care. The Rural Health Care Access Act repeals the 35-mile rule, arbitrarily selected, I might add, that prevents many rural hospitals from receiving a critical access hospital designation if they're less than 35 miles away from another hospital. This bill does not change any other requirement for hospitals to receive critical access designation. The 35-mile rule is the only change we're making to federal law. Hospitals that wish to receive this designation will still have to be designated as rural, only provide acute care, and primarily host patients for less than 96 hours. These critical access hospitals receive cost-based reimbursement from Medicare, greater flexibility for staffing and service requirements, and access to a variety of grant opportunities. This bill will help reduce the financial vulnerability of these rural critical hospitals, which often provide essential medical services in rural communities like the ones that I represent. My second piece of legislation targets a specific issue in hospital systems, emergency departments. H.R. 1129, the Rural ER Access Act, would repeal federal regulation that prohibits freestanding emergency departments from operating more than 35 miles from a hospital. This 35-mile rule, again arbitrarily selected, was instituted in the 1990s to monitor the safety of ER patients. HHS was concerned that if ERs opened too far from a self-standing hospital, then emergency patients would not have other medical options should the self-standing ER department fail in its mission to treat and triage. However, speaking as an ER physician who practiced medicine in rural areas across the nation, I know how advanced our medical technology is today, and I know how desperate some situations are. This antiquated rule is now hindering patient access rather than saving patient lives. By eliminating this mileage requirement, freestanding ERs would be able to provide frontline emergency care to rural communities that most desperately need it. During an emergency, these facilities can provide a crucial safety net, especially in rural communities where the nearest hospital is many miles away. Further, keeping an ER, should a hospital have to close, keeps jobs in a community. We also need to address the workforce burnout amongst medical providers by enacting H.R. 5213, the Reducing Medical Unnecessary Delays in Care Act. This legislation is endorsed by the Medical Group Management Association and the American Academy of Family Physicians, and it seeks to unburden our doctors from the bureaucratic red tape that is prior authorization. According to the Medical Group Management Association, 72% of medical groups report that clinicians assigned to complete their peer-to-peer reviews by the plans are not from a relevant specialty to the treatment or disease in question, resulting in dangerous delays and flat-out denials. In order to combat this worrying trend and reduce unnecessary delays in care, this bill would reform the practice of prior authorization in Medicare and Medicare Advantage. If my legislation becomes law, only board-certified physicians in the relevant specialty would be the ones making the important decisions about care. Specifically, it would also direct Medicare, Medicare Advantage, and Medicare Part D plans to comply with requirements and restrictions and must be based on medical necessity and written clinical criteria. And I'm going to break from my script for just a second to say this. When a physician reaches out to a health insurance or the Medicare for permission to do a procedure that it wants to do for its patient, they're oftentimes talking to someone who has no medical license, no care, and that individual makes the medical decision to take something off the table that the physician can use to heal that particular disease process. That is a medical decision. If there are 5 ways to heal something and the insurer or the Medicare or Medicaid patient or administrators take 3 of those away, that's a medical decision. And what this bill does is it says a physician that normally treats that type of disease should be the one making the decision at Medicare and Medicaid. What all these bills do is aim to restore our rural health system and save our doctors from needless paperwork. With this committee's help, I'm excited to get our medical system back on track. And finally, Mr. Chairman, and I know I've gone a little long, as a representative of Music City, I want to mention the HELP, Independent Track Succeed Act, HITS Act, which I have co-sponsored the past 3 Congresses and is so crucial for independent creators in Nashville who author and produce the hits we know and love. This bill makes much needed reforms to the tax code to ensure these creators receive the same treatment that other creative industries already get. I hope the committee can mark up this legislation in the near future. Thank you, and I yield back.